Hi, my name is David Weisman, and I am a cardiac electrophysiologist. I'm here today to talk about a topic that I'm very passionate about, atrial fibrillation. And today, specifically, what we're going to talk about are non-pharmacologic alternatives to medications for stroke prevention. A little background about myself. I'm a cardiologist, but I have a specialty or subspecialty in cardiac electrophysiology. That makes me a heart rhythm specialist. And I see a lot of patients with atrial fibrillation in my office, and most of them are coming to me with symptoms, but the primary question that I'm getting these days really is about what can I do to prevent my stroke without having to take blood thinners? So we're going to talk a little bit today about a procedure called the Watchman. So this is an EKG of someone in normal rhythm, and hopefully you have an EKG very similar to this one. This heart here is beating in normal rhythm, and what we'd like to see is that the upper chamber beats first, followed by the bottom chamber in a nice synchronous fashion. And this leads to normal blood flow. Unfortunately, a lot of people, and this number is growing, who have atrial fibrillation have an EKG like this one. And you kind of see here a very chaotic, irregular heartbeat and pattern. And here in this video, you can see a heart in atrial fibrillation where the upper chamber is beating 500-600 times a minute. And oftentimes the bottom chamber is racing as well, causing a lot of symptoms, and unfortunately can lead to stroke. And we'll talk a little bit about that in this talk. So a little background about atrial fibrillation and why it's important in our society. Approximately 2.7 to 6.1 million people have atrial fibrillation. Approximately 2% of people age 65 or less, or up to almost 10% of people by the time that they're 80 will actually develop atrial fibrillation. And that number is increasing. As the population grows and as we live longer, more and more people have atrial fibrillation. One of the biggest risk factors for actually developing atrial fibrillation is age. And why is this important? Atrial fibrillation actually contributes to about 750,000 hospitalizations, contributes to about 130,000 deaths every year, and costs our medical system $6 billion a year to take care of. So patients come to me, often referred by their cardiologist or sometimes referred by their internist or primary care physician. And we kind of set with them some goals of treatment. So typically, a lot of them come to me because they're having symptoms. They feel short of breath, they may have chest discomfort, dizziness, lightheadedness, fatigue is common. A lot of them will complain about symptoms of their heart racing or what we call palpitations. And that is kind of the first goal of care. But even perhaps more important to me is the second goal of care, and that's stroke prevention. Patients with atrial fibrillation are at much higher risk for stroke than the normal population, and so we have to mitigate that risk, and I'm going to go into some more detail in a second. So here's a kind of cartoon of a patient with atrial fibrillation with the heart beating out of the chest. Patients can feel sweaty, very uncomfortable, will often end up in an urgent care or their primary care physician's office. Frequently will go to the hospital, as I mentioned earlier, and this just doesn't feel good. This can lead to heart attack, stroke, and heart failure. Once they get diagnosed, which can be done with a simple EKG, their physicians will often prescribe them not one medicine, but also ultimately multiple medications, including something we call anticoagulants or blood thinners. These are not medicines like aspirin or Plavix, but specific medicines aimed at thinning the blood to reduce the risk of clot formation, which can form stroke. We call these medicines anticoagulants, or the layman term blood thinners. And I want to reiterate the point that antiplatelet agents, so agents like aspirin or clopidogrel, also known as Plavix, or medicines similar to that, have never been shown to reduce the risk of stroke in patients with atrial fibrillation. And a lot of these patients happen to be on these medicines anyways for other heart conditions, especially if they've had procedures where they've had stents placed inside their heart. So drugs that have been proven to reduce the risk of stroke and atrial fibrillation include the tried and true medicine, which is warfarin, also called Coumadin, which has been around for many, many years. Since that time, newer agents have come out on the market, starting with dabigatran, also known as Pradaxa. Then after that came out rivaroxaban, also called Xarelto. Subsequently came out apixaban, also called Eliquis. And more recently, we have a drug called edoxaban, also called Savaysa. And these are the most common agents that we have in the United States to reduce the risk for stroke. So the question is, if you have atrial fibrillation, what is your risk for stroke? So if you take all patients with atrial fibrillations, everyone's stroke risk is actually not the same. So how do we decide who's at a higher risk for stroke and may need further therapy to prevent and mitigate that risk? Well, the most commonly accepted practice for cardiologists and cardiac electrophysiologists like myself is to utilize an algorithm called the CHADS-VASc score. The CHADS-VASc score is basically an acronym where C stands for congestive heart failure, H for hypertension, age, if you're more than 75 years of age, we apply a certain number of points, and if you're 65 to 74 years of age, we apply a different number of points. Diabetes, stroke, if you have peripheral vascular disease like carotid artery disease or peripheral arterial disease, and also actually if you're a female. So all these things get a point unless you've had stroke and then you get 2 points, or if you're above the age of 75 and you get 2 points. Anyone with 2 points or more will be recommended a blood thinner because their risk of stroke is sufficient. So what is that risk? So with 2 points, your annual risk, in other words, your risk every year of having a stroke is 2.2%. And that number will simply increase as that person gets older because their cumulative risk will get higher. In addition, if they develop other comorbidities, other medical issues that fit into the CHADS-VASc score, let's say they develop diabetes at a later time, then that risk will subsequently also increase. So patients who have CHADS-VASc scores of 2 or more will be referred, initially at least, for anticoagulation or blood thinning therapy. And here we have a CT of the brain, and this is a normal CT of the brain. This is what we like to see. And this diagram kind of illuminates why atrial fibrillation can cause a stroke. So the heart has a direct communication to the brain. And when patients have atrial fibrillation, as I mentioned earlier, that upper chamber of the heart can beat very irregularly and chaotically up to 500 to 600 times a minute. When that happens, the blood no longer flows fluidly and can then coagulate and form a clot or a thrombus, as we call it in the medical world. And that thrombus can then embolize and travel upwards towards the brain, where it can occlude the blood vessels of the brain and lead to a stroke. When the blood vessels of the brain are occluded, that portion of the brain can die and lead to stroke symptoms. And here we have 2 CAT scans kind of illuminating what a typical stroke might look like in someone who has atrial fibrillation. In addition to atrial fibrillation being a risk factor for stroke, I want to underscore the fact that stroke from AFib can actually be much more disabling and has a higher risk of death than typical ischemic stroke that you might see for other reasons due to, let's say, plaque buildup in the brain. And so that further underscores the importance of identifying your risk and becoming treated for it if necessary. This illustration shows a picture of a transesophageal echocardiogram. This is an ultrasound that, as doctors, what we can place through the mouth and into the esophagus while you're sleeping and image this pouch inside the heart. This pouch is called the left atrial appendage. This is a pouch that everyone is born with. It's in the upper left chamber of the heart, and this pouch is where the majority of clots or thrombi form during atrial fibrillation. When that clot forms, this is where it embolizes from and can go to the brain to cause stroke. And I mention this because this is the ultimate target for the implant that we call the Watchman. So patients, the natural question is patients who get placed on blood thinners are worried about safety. Primarily they're worried about their risk of bleeding. If I take this and I cut myself, what's going to happen? Or if I'm in an accident, what's going to happen? Or if I'm in some remote area and I start bleeding, am I in danger of dying? So in addition to the CHADS-VASc score, There are many algorithms to kind of help us determine who is at increased risk for bleeding. And one of the most utilized algorithms is something called the Hasbled criteria. And this is meant to be a kind of supplemental algorithm, really to help us identify the risk benefit of being on a blood thinner. We know that the risk benefit of being on a blood thinner in someone who has AFib occurs when their CHA2DS2-VASc score is 2 or greater. But we also want to know what their safety is for taking those blood thinners. So the Hasbled has been developed, and the Hasbled is an acronym, and it stands for hypertension, patients who have abnormal renal, meaning kidney or liver function, if they've had a stroke before, if they've had history of bleeding, if they have label, meaning very irregular INRs, which is a laboratory measure for patients who take warfarin and Coumadin, and if they're above the age of 65 and or drink alcohol or use drugs. So for all these things, they receive a point or two, and depending on their total score, we can assign a risk of bleeding per 100 patient years. And we determined that patients with a Hasbled score of 3 or more might be at sufficiently higher risk for bleeding that we might not want to consider putting them on a blood thinner or consider a non-pharmacological alternative like the Watchman. And this is a kind of summary recommendation of what I just talked about. We have the CHA2DS2-VASc and the Hasbled, and for the CHA2DS2-VASc, basically, if you're an atrial fibrillation patient with no risk factors and a CHA2DS2-VASc score of 0, really no medical therapy is recommended because your overall stroke risk is sufficiently low enough. If you have a score of 1, in general, it's a kind of shared decision-making between the patient and the physician as to whether or not they should go on an anticoagulant or blood thinner. Majority of them may, depending on their overall risk. But in general, as physicians, we still prefer blood thinning agents. When their score gets to 2 or more, we usually recommend a blood thinner unless there's an obvious contraindication, meaning there's some reason why they shouldn't be on that. And in addition, as I mentioned, we have the Hasbled, and this is the kind of counterpart to the CHA2DS2-VASc, an algorithm to help us determine overall bleeding risk. And those with a Hasbled score of 3 or more, we might not want to consider putting them on a blood thinner, and perhaps now consider something else like the Watchman. So here we have an animation of a patient undergoing a Watchman procedure. They'll come to the hospital, meet the anesthesiologist. Subsequent to that, will be brought to a specialized room where they'll undergo general anesthesia. Once they're under general anesthesia, we pass that transesophageal echo probe, that special camera where we can visualize the heart by passing it into the esophagus through the mouth. We visualize that pouch and then go ahead and start the procedure. That involves getting access of the vein in the groin area under an ultrasound guidance. We pass a special delivery sheath up into the heart, gain access to the left upper chamber of the heart. Once we're there, here you can see the sheath going into this appendage. And these appendages often have funny names like windsock and broccoli, but their names really are not that important. We take pictures of the appendage in order to size it properly to determine what size Watchman we need. They come in different sizes. Some people have smaller appendages, some people have bigger appendages, and that Watchman is sized for the patient. So once this sheath is in the appendage, we'll actually unsheath it, allowing the Watchman to be deployed at the opening of this appendage, hopefully sealing it. Once we determine that the Watchman is stable and it's not going to go anywhere, and also completely sealing off the opening to our satisfaction, we'll actually release it, and it will then become part of the heart wall. We'll confirm this by the ultrasound that's already in place, and the ultrasound will make sure there's no leaks around this device. And over time, what will actually happen is tissue will form, and we call that endothelialization. So tissue will form over the surface of the Watchman and actually become part of the heart wall and will become indistinguishable. From there on, the patient will wake up, they'll go to a regular room and stay overnight, and the following day, ideally be discharged. These patients will go on a blood thinner and an aspirin, and we'll talk a little bit about the post-implant protocol here in a second. So the next question, obviously, is then, who is a candidate? So obviously, someone has to have a history of atrial fibrillation or its cousin, atrial flutter. Next thing is they have to have a CHADS-VAX score of 2 or greater. That means that their annual risk of stroke is going to be 2.2% or more. The next thing is there has to be a rationale for why that patient cannot take a blood thinner. So some common things as to why reasons why patients cannot take blood thinners. They've had a major bleeding event. They've had perhaps gastrointestinal bleeding, or maybe they've had some other life-threatening bleeding events. They may have a lifestyle, occupation, or some kind of condition that puts them at high risk. Perhaps you work on heavy machinery, or you ride horses, or you do something that you're worried that if you cut yourself, you could have a really serious problem on your hands. The other issue is having difficulties taking blood thinners. These are patients who've tried the blood thinners and they just haven't been able to tolerate them very well for various reasons. So patients on warfarin or Coumadin may have labile or very irregular INRs. That's the blood measurement for the level of thinness of the blood for patients on Coumadin. We also often get complaints for those patients as well that they have dietary restrictions that they just can't manage, and that becomes intolerable for them. Missing doses is a big key. So, unfortunately, whether you're symptomatic or not from atrial fibrillation, if you miss your blood thinner, you're putting yourself at risk for stroke. So some patients have compliance issues and perhaps don't remember all the time to take their medicine. So the Watchman circumvents that. And the big thing that we see is inability to afford the medication. So cost is an issue. A lot of these newer medicines, not so much warfarin and Coumadin, but the Xareltos and the Eliquises and the Pradaxes of the world, they're wonderful medicines, but a lot of patients, depending on their insurance plan and their coverage, just cannot afford these medicines. And who is at high risk for bleeding? So we talked already about the Hasbled having a score of 3 or greater. And I think a history of the following is important to underscore. Obviously, having had a history of bleeding in the past, frequently we see things like gastrointestinal bleeding to be common. Those who are high risk for bleeding, I would say patients who are on NSAIDs, so anti-inflammatory medicines like prednisone, or perhaps you take Aleve, naproxen, Mobic, Advil, for chronic back pain. Those are medicines that we don't want you taking concurrently with your blood thinners because they certainly will increase your risk for bleeding. Another thing that I see quite often is a history of falling or a history of fainting. Unexpected falling and fainting, if you hit your head, you can have a really traumatic brain bleed, and this can be a concern. So if we start seeing that this is a pattern, or we have something unexpected where we're concerned that this could happen again, I think blood thinners might not be suitable for you, and perhaps a Watchman might be a good alternative. And as I mentioned earlier, people who participate in high-risk activities, depending on their job, lifestyle, or occupation, that might be something to consider depending on that individual's circumstance. So what is the post-implant protocol? So immediately after the Watchman, we'll be putting them on an anticoagulant, typically a medicine like Xarelto or Eliquis, and an aspirin. You'll go on that medicine for 45 days, and at 45 days, we'll do a post-implant transesophageal echocardiogram. That's that ultrasound, again, that we place in the mouth to take a look at the heart. And in this case, we're actually looking to see that the Watchman has completely sealed off the opening or the pouch inside. The majority of patients, this will happen at 45 days. And at that time, we can actually discontinue the blood thinner, continue the aspirin, and add in a medicine called clopidogrel or Plavix, which is a really common antiplatelet agent that we use in other heart patients. Patients will stay on this for up to 6 months, at which point we'll actually trim their medicines and stop the clopidogrel and then just go to aspirin alone. And at this time, the Watchman usually is fully healed and their stroke risk is mitigated by the device. And this is basically the Watchman in a nutshell. So I have here a list of questions that patients will typically ask me in the office. If I have the Watchman put in, do I still have to worry about my AFib? The answer is yes. Watchman only mitigates the risk for stroke. It does not take away the fact that you still have atrial fibrillation. So if you suffer from symptoms related to atrial fibrillation, you still may need further therapies related to that. The next question that I get is, can I still get the Watchman if I've had a cardiac ablation or a cardiac pacemaker or cardiac surgery? And the answer is still yes. Having had those procedures in the past does not make you not a candidate to have the Watchman. And what's the recovery time? Actually, the recovery time from the Watchman is quite good. You know, the real thing that you're healing from is the access in the vein in the groin. That typically takes a few days, up to a week. You may see a little bit of bruising, maybe some minor bleeding at that area. But as long as you do light activity, you know, don't exercise or do any kind of heavy lifting, within a few days to a week, you can basically go back to your normal everyday life. Does my insurance cover the Watchman? This is obviously very important, and the answer is yes. Obviously, you know, depending on what you have, you know, if you have a commercial plan, we'll authorize the procedure before ever going to the hospital. Medicare certainly covers the Watchman. The next question I frequently get is, I'm already on aspirin and Plavix. Do I still need to be on a blood thinner or have the Watchman? And as I stated in my talk, these medicines have never, ever been shown to reduce the risk of stroke in atrial fibrillation, and so they're not sufficient. So if you're on aspirin and Plavix because let's say you've had a stent inside your heart, you're still going to need something to prevent the risk of stroke. Now, that patient might be a good candidate for the Watchman and not a blood thinner, because taking aspirin, Plavix, plus a blood thinner might be too much, and that person might have a very high risk of bleeding. So you might be a candidate for this non-pharmacological alternative. And the last question here that I get is, do I need to stay overnight in the hospital? So yes, the protocol is it's a one-night stay in the hospital. Typically, you're out the following morning, and then we'll follow you up in the office for routine follow-up. At that time, we'll schedule you for the 45 or 6 week 45-day or 6-week transesophageal echo to confirm sealing of the left atrial appendage with the Watchman. And if that looks good, we'll continue to trim your medicines down over the next few months up to a year. So if you enjoyed my talk today on the Watchman, I have other talks on atrial fibrillation management beyond the Watchman. And if you're interested, you can go to the Palm Beach Gardens Facebook or YouTube pages and view them at your leisure. I have 2 offices, one in Palm Beach Gardens on Burns Road across from the hospital, and the other in West Palm Beach on Flagler Drive. You can also go to drdavidweisman.com. Right now we're offering telehealth visits and virtual visits, especially during this time. And I'm happy to see new or existing patients to talk about Watchman as an option if you feel you might be a candidate. Thank you very much.